Hi guys. So today we'll talk about vas deferens and prostate. These are the main male genital organs, which are testis, epididymis, vas deferens, seminal vesicles, prostate, bulbourethral glands, and the penis. Ductus deferens is also called vas deferens, which is a thick-walled structure made of smooth muscle. The thickness of the smooth muscles are so much that the lumen is very narrow. So it looks like a whip cord. So the function of vas deferens is to connect the tail of the epididymis to the near area of seminal vesicle, where the vas deferens and the seminal vesicles joins to form ejaculatory duct. That is further reaching the prostatic urethra inside the prostate. The length is 45 centimeter. Ductus deferens continues as the tail of epididymis. So it starts from here all the way and it enters the spermatocord. Spermatocord is a structure that is connected to the testes. In the spermatocord, that is over here, it lies on the posterior aspect of spermatocord. When it moves above, it is going to enter into the inguinal canal through the superficial inguinal ring. Then it remains in the inguinal canal. It passes through the inguinal canal. It reaches deep inguinal ring. At that point, it leaves the spermatocord and it is going to wind around the lateral aspect of inferior epigastric artery. So that means it is almost reached in the abdomen. Then it crosses into the pelvis, initially the lateral pelvis, then in the lesser pelvis. So it reaches somewhere near the bladder right now, above the bladder initially. Then it passes posterior to the bladder, where it joins with the duct of seminal vesicle. And both of them, that is the duct of seminal vesicle and the ejaculatory duct of same side, it is going to form something called as ejaculatory duct. This ejaculatory duct will be penetrating the prostate. So this is a figure where the spermatic cord can be seen, which is attached to the testis. Let's discuss about blood supply of the vas deferens. It is supplied by artery to ductus deferens, which is a small artery arising from superior vesical artery, which is a branch of internal iliac artery. Veins from the ductus deferens that joins vesical venous plexus, that is seen on the infralateral surface of urinary bladder. From there, it drains into internal iliac vein. Clinical aspects: vasectomy or differentectomy. So it's a common procedure which is used for sterilizing males, where in this procedure it is a OP procedure where the procedure is done under local anesthesia. So lower aspect of the penis or the upper aspect of the scrotum, where an incision is made, where the ductus deferens is found, and that has been cut and ligated. So when you do this, the sperm which is there in the testis will not be entering into the remaining part of the cut part of the ductus deferens, so that the semen does not contain sperm, but it contains the fluid from seminal vesicles, prostate, and the bulbourethral glands. So after doing this procedure, the sperm that is produced in the testis will be destructed or phagocytosed by cells which are there in the testis. The next gland, that is seminal vesicle, which are sac-like structures placed between urinary bladder and the rectum. As I mentioned before, that the lower part of the seminal vesicle, which is tubular, and that will join with the ductus deferens, and that form something called as ejaculatory duct. Remember, seminal vesicles are not the area to store the spermatozoa. Spermatozoa are stored in the epididymis. Seminal gland is going to produce alkaline solution, which is mainly consisting of fructose. And the secretion will be helping or will allow the sperms to have nutrition. Also, it adds about 70% of seminal fluid. So this is the seminal gland, where upper part is enlarged, whereas the lower part, that is tubular, where you can see the ductus deferens also joins with the seminal vesicle to form vas deferens. Ejaculatory duct. Ductus deferens will join with the seminal vesicle to form the ejaculatory duct. Moving on to the relations of seminal vesicle, the upper part, that is enlarged, and the lower part is tubular. Upper part is related to the peritoneum, and that peritoneum is reflected from the urinary bladder to the rectum. So it is related to a pouch over here that's called rectovesical pouch. Whereas the inferior end of the seminal vesicle, which is tubular, which is not having any relation with the peritoneum, but it is related to rectovesical septum. Rectovesical septum is nothing but it is a primitive rectovesical pouch. The lower part of the rectovesical pouch is obliterated, and that is called rectovesical septum, which is also called as fascia of Denon bilious. The next gland is prostate. So it's an accessory gland of male reproductive system, which is firm in consistency and it is fibromuscular. So the prostate gland, half of the prostate gland is glandular, 1/4 is muscle, smooth muscle, 1/4 is fibrous tissue, and it lies in the lesser pelvis, just below the urinary bladder. In the females, prostate is absent, but it is replaced by paraurethral glands of skinny. Prostate resembles a chestnut, and it is like inverted cone, where the base is above and the apex is below. It has got 4 surfaces: anterior surface, posterior surface, and 2 infralateral surface on the sides. Base is above and it is upwards, facing the urinary bladder, and it is related to the neck of the urinary bladder. So lower part of the urinary bladder, somewhere here, that's called the neck. Apex is in contact with the urogenital diaphragm, and there's a fascia which is above the urogenital diaphragm, that is called superior fascia of urogenital diaphragm, and this is urinary bladder, and the base is related to the urinary bladder, apex is related to urogenital diaphragm. Whereas its anterior surface, it is separated from the pubis by a retroperitoneal fat, which is intervening between the pubis and the prostate. Also, it is connected to the pubic bones by puboprostatic ligaments. There are 2 puboprostatic ligament, one is lateral, other one is medial, and it is a paired structure, both of them. Posterior surface of the prostate. We can divide the posterior surface of the prostate into upper part and a lower part by a transverse sulcus. The lower part can be again divided into right and left part by a posterior medial sulcus. Somewhere between the transverse sulcus, that is on either side of the transverse sulcus, ejaculatory ducts are entering into the prostate. That's over here. So this is for the right ejaculatory duct, this is for the left ejaculatory duct. And the posterior surface is related to the ampulla of the rectum, where there is a fascia that is called fascia of de nonillars. Infrolateral surface is related to the pelvic diaphragm, that is made of levator ana muscle. Also, it is related to anterior recess of ischorectal fossa. We may be able to divide the prostate according to a distribution of prostatic disease into zones. So prostatic diseases such as cancer and benign prostatic hypertrophy. So the majority of the part of the prostate, that is somewhere here, all this area, that is called the peripheral zone, which contributes almost 70% of the gland. That's over here. And this is cancer vulnerable area. Whereas 25% that is called a central zone, which is posterior to the urethra, somewhere here. Especially we can say this is the area which is surrounding the ejaculatory duct. So ejaculatory duct is somewhere here. So over this area, whatever part of the prostate, that is called the central zone. So here, this is derived from a Wolffian system, that is Wolffian duct system, that is called the mesonephric duct. So this area is derived from the mesoderm, whereas the remaining area, that is the peripheral zone, as well as the next one, that is the transition zone, these are derived from endoderm. Anyway, let's see what is transition zone, which is very less, 5%, which is called periurethral transition zone, which is around the urethra, and where we may have a prostatic hyperplasia. So basically, except the central zone, the remaining part of the prostate may have diseases like the peripheral zone, which can go for cancer, and the periurethral transition zone that can go for benign prostatic hypertrophy. Remember, the periurethral zone, that is transition zone, and the peripheral zone, these are derived from endoderm, whereas the central zone, which is derived from mesoderm. We can have classification of prostate as lobes. So there is a concept which is called old theory, and there is a new theory as well. According to the old theory, there are 5 lobes for the prostate, which is anterior, in front of the urethra, lateral, which is seen on either side of the urethra. Then on the posterior aspect, there are 2 lobes, upper part, that is median lobe, and lower part, that is posterior lobe. To make it more clear, posteriorly there are 2 lobes. Upper part is called the median lobe, whereas the lower part is called posterior lobe. Let me explain further. Posteriorly there is ejaculatory duct, which is entering the prostate. So the part of the prostate that is behind the upper part of urethra, above the ejaculatory duct, this part is called median lobe, which is very close to the neck of the urinary bladder. Whereas there is a part of the prostate that is lying below the ejaculatory duct, behind the lower part of prostatic urethra, that is called posterior lobe. So altogether we have got 5 lobes: anterior 1, 2 lateral, then 1 median, and posterior. So these are the lateral lobes, anterior lobes, median, posterior lobe. According to the NEET theory, there are 3 lobes. That is, I hope you remember this picture, which is showing the posterior surface of the prostate. So on either side of the posterior median sulcus, these lobes which are lying on this area, that's called lateral lobe. And above the transverse sulcus, this area, that area is called, or that is called the median lobe. Now let's see the structures that is within the prostate. So the first one is prostatic urethra, which is at the junction of anterior 1/3 and posterior 1/3 of the prostate. So inside the prostate, there is prostatic urethra. This is the posterior wall of the prostatic urethra, where there is an elevation that is called the urethral crest. In the middle of the urethral crest, there is opening of prostatic utricle. So somewhere here, this is the prostatic urethra, and this elevation is called urethral crest. And somewhere at the there's a urethral crest. Somewhere at the junction here, that is the prostatic utricle opening. Prostatic utricle is nothing but these are the absorbed paramesonephric duct. So it represents the vagina, and it's a remnant of the vagina, where on either side of the prostatic utricle there are opening of ejaculatory duct. Ejaculatory ducts were entering the prostate from the posterior aspect of the prostate. There are coverings for the prostate. The first one, that is called a true capsule, which is nothing but the condensation of the fibromuscular structure, that is stroma of the gland. Where there is another one that is called false capsule, which is nothing but the modification of the pelvic fascia. Between the true capsule and the false capsule, there are a lot of venous plexus. As I mentioned before, the false capsule, that is nothing but endopelvic fascia. Anteriorly, it is continuing, and it is called the puboprostatic ligaments. As I mentioned before, there are 2 medial and lateral puboprostatic ligaments. Whereas posteriorly, it is continuing as a fascia of Denon Villiers, which is a primitive rectovesical pouch. Prostate is supplied by inferior vesicle, middle rectal, and internal pudendal arteries. And these are the branches of internal iliac artery, anterior division. Whereas the veins, these forms a plexus surrounding the prostate, and they drain into internal iliac vein. Also, some part of the prostate that may drain the prostate, and then it passes through the anterior sacral foramina, and it can reach the vertebral venous plexus. Sympathetic nerve supply is from superior hypogastric plexus. Parasympathetic are secretomotor in nature. That means it allows the secretion of prostate, and these are derived from pelvic splanchnic nerves, which are derived from S2, S3, S4 spinal segments. So this is superior hypogastric plexus, a sympathetic one. Lymphatics from the prostate, that is draining mainly to internal iliac, sacral lymph nodes. So at the birth, especially first 6 weeks, there is a lot of hypoplasia in the prostate. Also, there is hyperplasia of prostatic utricle. But after 9 years, changes are negligible. In puberty, again, there is a hyperplasia. That is because of male hormones. Then 20 to 30 years, marked proliferation of glandular elements can be seen in the prostate. 30 to 45 years, prostate remains almost constant in the size of it. Whereas 45 to 50 years, there are two possibilities. One, it can go for reduced in size, atrophy. Other one is hypertrophy. So there can be enlargement of prostate. Enlargement of prostate, most of the time, it involves the medial lobe, which is very close to the neck of the urinary bladder. So that can cause difficulty in voiding urine. As the patient strains, there will be more difficulty in voiding the urine. So the patient is unable to void the urine completely. In case of this, we may have to remove the prostate. That is called prostatectomy. The mostly used approach is transurethral, that is transurethral resection. Inflammation of the prostate is called prostatitis, and carcinoma can be seen after the age of 50 to 55 years. A case scenario where a 65-year-old man had a prostatectomy done 2 years ago. Because of low backache, he got an X-ray of his spine done, which shows secondaries in the lumbar vertebra. So how do the cancer cells spreads to lumbar vertebra? So as I mentioned before, the prostate venous drainage. The veins from the prostate drains into vertebral venous plexus, which are also called as Battson's plexus. So the cancer cells might have moved from the prostate and reached the vertebral venous plexus. That is why the patient is developing some secondaries in the lumbar vertebra. The next question here is, where else can these spread and how? So once the cancer cells has reached the vertebral venous plexus, it can easily go up to the higher areas, like higher parts, like the upper aspect of the vertebral canal, and it can reach even the cranial cavity. Thank you.